hit record. Good morning, everybody. It is a distinct pleasure to introduce to you a colleague I've known for around 14 years, Dr. Kwan Lee, who is actually presently in Colombia, and he's been traveling the world recently, going to various conferences. Dr. Lee obtained his MD degree at Trinity College in Ireland and subsequently completed residency and cardiovascular medicine fellowship at the Mayo Clinic in Scottsdale, interventional cardiology fellowship at Emory, and he ended up as faculty when I was a young general fellow at the University of Arizona, where he stayed for a number of years, became professor of medicine, and actually interim chief of cardiology before moving on now, and he's about to start at the Mayo Clinic in Scottsdale, where he began his U.S. career. He's been, as an educator and as a cardiologist, his teaching points that he imparted upon me have stayed with me all these years, and that speaks to the caliber of the person he is. So, Kwan, welcome, and please take it away.
Thank you very much, Rob and Kartik, for this opportunity to be with you today. It's such an honor and a privilege, and it's so good to see you again, Rob. It's great to see that you've gone in and done great things. I think that's the most special part of being involved in someone's training. Just some housekeeping stuff. I'm in Colombia right now, and there are some strange noises that have been coming up overnight from the fire alarm. They seem to have stopped, but if you hear something that sounds like an alarm, don't get alarmed. It's just technical issues on this side in South America. My topic for this morning is digital simulation in interventional cardiology education. I think this issue is especially timely given the upcoming release of the 2022 competency statement for interventional cardiology that has been quite contentious and debated on for almost a few years now. It will define exactly what it means for us to be interventional cardiologists and what our training should be, as well as the recent pressures on volumes and training that the COVID-19 pandemic has forced upon us. And also, it's worth noting that SCI in 2014 issued a position statement on simulation, but I would say overall that in the last 8 years that we have really not made much progress. So I think this is a review and hopefully a call to arms. Let me proceed. Okay. My only relevant disclosure is that I did work on simulation modules for the simulation company Mentis. I have found that trying to work with the official society was a little frustrating because we couldn't actually change the substrate. So I actually decided to buy myself a plane ticket and fly to Sweden and then work on their modules for interventional cardiology. So just to have an overview of what we are going to learn today. First of all, we'll start by reviewing simulation and its philosophy and principles. I think it's worthwhile just clarifying some issues. And then let's look together at the recommendations for application of simulation in fellowship, training, and accreditation, both in the United States and in Europe. And then we should look together at the available simulation technology for interventional cardiology education. We'll look at the evidence for simulation in cardiovascular education, and then try and wrap up by looking at the challenges in the use of simulation as it pertains to training and our potential future research directions. So let's start with philosophy and principles. The obvious question as to why simulate. We have a lot of other industries and fields to look at, and this is especially apropos with the launch of the Artemis rocket last night. I think flight simulation and military simulation is probably the gold standard around the world. And despite everything that we have talked about in the philosophical position that simulation is the right thing to do, I think simulation in medicine has struggled to try and make us or embed itself as firmly as simulation has in the aerospace industry. I think The Mayo brothers put it nicely, and it's quite amazing how prescient they are, though they were, essentially back in the, I think, 1800s or early 1900s, William Mayo basically said there is no excuse today for the surgeon to learn on the patient. Despite this call to arms, almost a century ago, I think as it stands currently, some of our education still occurs on the patient. Sorry. All right. There have been several papers and position statements and opinion pieces over the years, and I think COVID-19 especially placed lots of challenges when it came to volume in interventional cardiology training. The upcoming training document is going to mandate 250 cases, which has been the case for a long time, to finish interventional training. And 50 of these are actually going to be not necessarily coronary cases. And I think there has been a lot of discussion as to whether this represents a regression and whether that is enough for a person to truly achieve competency. And then there was some interesting papers, such as, especially with regards to our women in cardiology colleagues, that discuss pregnancy during fellowship in training and their experience with simulation. It's also worth noting that this paper here on simulation present and future roles by David Holmes was written almost 15 years ago. And despite that, we have not made that much progress. What are the factors that favor simulation training in cardiology? There's obviously continuous development and evolution of more complex interventions. There's inconsistent exposure with the apprenticeship model of training. Work hour restrictions have limited the number of cases. Procedural numbers overall are falling in some places. Some procedures have steep learning curves. We obviously have the potential for life-threatening complications. And, being able to use simulation, we should be able to control a training schedule around a work schedule more consistently. And we also need to move away from quantitative to qualitative thresholds, and the new document makes a strong point of that. What are the models of medical training? The obvious old adage of see one, do one, teach one is from the earlier part of this century. The apprenticeship model of training is the model that most of us use, I think, still. And then there are other models where we train according to the speed of an individual, and that's competency based. But that has actually, as we all know, has been very hard to implement. And ultimately, we should truly look to learn the operation before the operating room. What types of trainers are there? And this is an important point. There are the most basic trainer is a task trainer, where you have a mechanical or digital model which allows repeated practice of a specific skill set. And in the world of digital interventional training, I would argue that most of our digital trainers are actually task trainers. They are not the ideal of the full hybrid simulator, which is a simulator which aims to achieve the highest level of fidelity with multiple possible scenarios. I put in capital letters at the bottom of the page the idea of proctors and debriefing, because in our experience, and I think the global experience of utilization of simulation, proctors are critical to the process of simulation training, and debriefing is critical. And herein lies the main problem with its widespread implementation. It's important to understand the concept of fidelity, and I think this is obvious. You have low fidelity structures which don't look real, all the way to high fidelity structures where you try and recreate an entire, say, cath lab environment within the simulation scenarios. And obviously, as you move from one direction to the other, the resource intensity increases. There's also the question of simply frequency and supervision. How often should simulation be used? Is it daily, weekly, monthly, quarterly, annually? And then the concept of retention. How effective is simulation? And how much does one retain when one is exposed to simulation training? And then ultimately also the big question, how much supervision? Can we allow our fellows to self-guide themselves through that education, or must you be proctored? What are the best techniques? There's been about 30 or 40 years of simulation training research, especially from the Center for Medical Simulation at Harvard. And I think overall, we found that individualized training is obviously the gold standard. The performance must be benchmarked to a specific level. You must have metric-based feedback, and you must train to achieve very specific competencies. It is not helpful to just have a simulator sitting around to which people are not working towards a specific target. And it's also important to recognize that poorly conducted simulation can enforce incorrect behavior. So if it is done, it should really be done well. Where do we stand with regards to where simulation is in current education and accreditation? If you look at the ACGME program requirements documents, and this has been true for at least the last 10 years in any of our subspecialty fields, under Section 4, Curriculum, Organization, and Fellow Experiences, there is a very strong statement. It says that fellows must participate in training using simulation. The document, however, does nothing to define exactly what it means by this. Is the provision of a CPR mannequin and pushing down on it once a year the definition of simulation? No one has actually gone out on a limb to actually say what that means. When you look at COCAT's Task Force 10, and this is our 2015 document, the concept of simulation is only introduced in the context of evaluation. They said that the tools for evaluation include simulation and reflection and self-assessment. What about the Europeans? How have the Europeans thought about simulation? In the latest 2020 EAPCI core curriculum, they have gone on to now start to hopefully move in the direction of actually clearly defining what they mean. Here, the Europeans say that training centers should be encouraged to incorporate on-site interventional cardiology simulators, and that is a bold statement. As we know, a lot of these simulators can cost up to $250,000, or to provide simulation sessions during IC training, especially during the early phases of training of the trainee and or the technique. When it comes to the ESC overall core curriculum, they say that role play with advances in the methodology of simulation training and technology facilitate task and team training in a safe environment. And I think that's also critical, that the training of the utilization of simulation is not just for individual training, but also for the team. And that's especially so in the cath lab, in our complex multi-personnel environments. This is an interesting historical aside. In 2008, ABIM introduced the option for earning credit via simulation in the self-evaluation of medical knowledge requirement for maintenance of certification of interventional cardiologists. And this was initially achieved through the MSC's SimSuite platform. And they had 5 case scenarios, and they offered it at SimSuite education centers or at national meetings. As of 2022, MSC has been absorbed by Mentis, and so Mentis provides the platform, and it's currently only offered at ACC, SCI, and TCT meetings. There have been no updates on the modules. The modules have not been changed in any way, with no release of public data on uptake or performance. I'm not sure how many of you here have tried these simulators, this specific module. I did it maybe 7 years ago, and I did not find it to be especially helpful, but here it is, and it's sitting out there. And this is the information slide from the ABIM. Takes about 2 hours to complete. It's worth 20 MOC points, and it's specifically, you can sign up in ACC, SCI, and TCT. In the upcoming 2022 ACC-HA SCI Advanced Training Statement on Interventional Cardiology, in the version that went up for public statement, the actual final document is still under embargo. The word simulation is mentioned 8 times, and this time you can see as an evolution from the 2015 data, it has moved away from simply being an evaluation tool. And similar to the Europeans, they have recognized that it should also be a training tool, specifically in the setting of procedures for complications, which are infrequent, procedures a program does not have access to, low frequency procedures, and uncommon clinical conditions to generate familiarity. So at least now we have some clarity as to what we mean and what competencies we should build our simulation modules towards. Hold on a second. Okay. I put this slide up just out of interest. there has been a movement overall where industry has started to play a more prominent role with regards to the education of some of our procedures. And I think that has been especially true in the field of TAVR and MitraClip, as well as the Watchman procedure. Whenever you bring up the idea that industry should be in charge of the education of a procedure, you tend to get quite a bit of pushback. But I think thus far, industry has done a phenomenal job as to standardizing and rolling out the education for these procedures. There are many expensive simulation modules that have been paid for and funded exclusively via industry. And these are not available even if you buy your Mentis platforms. And I think it bears thinking about, the many questions should abound from this specific phenomenon, such as, should there be formal standards for module development? And what kind of access should we try and demand, I suppose, of our industry partners? Right now, they will not let you use their modules outside of access granted by the companies themselves. And I think that's an interesting point. So let's look together at modern endovascular digital simulators. They generally use mechanical haptic feedback, and this is achieved by a series of motorized carts which lock onto inserted instruments as you push against them, and there are wheels or lasers that then measure the movement of the thing you're pushing, and then it pushes back against you in a digital environment. And then you tend to have these simulated control of C-arm and patient table with fluoroscopic, etc. And they tend to have some degree of physiological simulation, although these tend to be quite simplistic. There used to be 4 major companies, Mentis, Symbionics, Medical Simulation Corporation in Denver, and CAE Healthcare in Montreal, Quebec. But SimSuite went out of business and was wrapped up by Mentis, and there are currently 3 primary companies. These are what your simulators look like. I'm not sure in Yale whether you have them. I suppose you must have 1 or 2 of these lying around somewhere. But this is the current G7 Plus. Above here, the Mentis module, which actually has 2 cards, and this allows you to do bifurcation PCI. There's this over here on the right corner. I'm not sure if you can see my little arrow here. That is a ICE or a TEE test trainer, and that device is actually surprisingly good. That's one of our most popular simulators on my site. There is a large spectrum of portability. You have these tiny task trainers that are just basically attached to laptops, and these go all the way up to a full simulated mannequin. Laerdal has an interesting mannequin that has a Mentis embedded within it that allows you to have access to full physiological simulation for code environments. So these are all the procedures that have been built in. Obviously, cornea angiography, left heart cath, Mentis and Symbionics have SVG graph engagement. Intracorneal physiology is represented. There is no good IBP simulator overall. Impella, I think, is run by CAE. They do have a simulation module with regards to the catheter positioning and echocardiography to check position. The rotational atherectomy module used to be very good under MSC, but has since deteriorated since it went over to Mentis. And I think probably for rotational atherectomy, just having a wet model is best, not digital model. And then there are many interesting companies that are working on right heart cath. There's quite a good CTO modules, and then radial access is well done by Terumo. And most interestingly, recently, there's been an excellent bifurcation module that was built and endorsed by the European Bifurcation Club on the Mentis G7 Plus platform. When it comes to structural work, transeptal is done quite nicely. PFO ASDs are also quite good. And then balloon valve, aortic balloon valvoplasty, good. Mitral balloon valvoplasty, not so good. Watchman those are good modules. There is no septal ablation module. The MitraClip module is a wet model. It's not a digital model, but that's actually a pretty interesting device. And then TAVI is well done by all three companies. Probably the peripheral suite is the best. I think our vascular surgeons and interventional radiologists have really led the way when it comes to the application of simulation to training. And there are, I think they have taken it much further than we have. And there's an entire suite of all possible vascular procedures for most of the platforms. There is IVUS and OCT. Abbott commissioned Ventis to build an OCT simulator. There is ICE and TEE simulators as well. And some of the interesting things with the TEE simulator is the use of augmented reality with headsets during the performance of TEEs. This is a slide just showing some of the capabilities of the recent European Bifurcation Club module from the Mentis G7 Plus. They allow you to simulate provisional stenting, TAP, culotte, and reverse culotte, as well as DK crush. And I think the DK crush one is especially interesting given the giant debate between the EBC and Asia on the primacy of DK crush, and the argument from the European side that you can't really do it unless you're good at it, but you can't be good at it unless you do it. And it's a circular argument, and this might be a way of actually breaking that impasse. Here is let me go back. Here is a picture, a representation of what some of these simulations look like. I think on this top part here is a very interesting feature of the simulation, the simulator, in that it allows you, as you work on it, to have anatomical visualization overlay. And I think for early trainees, it's very good and it shortcuts a lot of the conceptual framework that you struggle to put together. This slight moving GIF here on the right is interesting. We have also built directional overlays so that you can see as you manipulate your catheter, we have heads-up displays that allow you to see different things, such as the actual direction that your catheter is clocking or counterclocking as you start to familiarize yourself with these concepts. And then, there's pictures of intracoronary physiology, dual injection here, as well as OCT in the corner as well, and IVUS. One of the other things that the simulation environment allows you to do is the study of radiation and radiation exposure. And here, at the end of your case, you can look at, they show you the visualization of how much radiation you're spraying around the room. And that's something that, you can't see in real life, so it's quite nice. Symbionics in their self-expanding TAVR module has built certain interesting things like the ability to deal with complications such as frame snaring and dealing with acute rupture and pericardial effusions. Here is another fascinating direction, and this has been used much more so in the vascular space because the hearts, the structures don't move, so that allows them to do this, where you can personalize the simulation that you're about to work on by importing CT data into the simulation environment so that you can test out catheters, approaches, etc., prior to moving on to the real patient. There's been some idea as to using coronary CT scans to implant under the same situation, the same methodology, but that's harder to implement as the heart moves. And so it's harder to map that model onto thing, but it would be a interesting research direction to go towards. This is a flow chart of the kind of clinical branch decision node points that in a typical Mentis or Symbionics scenario. As you can see, this specific case is for mid-RCA lesion, and here the case does not go well unless you perform aspiration thrombectomy. As you know, this is no longer a class 1 indication and has become a class 3 indication. And so, unfortunately, I think the modules suffer from oversimplification, as you can imagine, and therefore, probably we need to build a way for us to be able to make these more sophisticated and more responsive to reality. It's I think, too linear. But as you can imagine, these things are hard to build, and the funding is not great. What kind of data do you get after you perform a simulation? And this is an example of the type of granular data that of your performance that is collected during the simulation. If you're actually interested in the granular output for which you could use to perform a research study, for example. There are complications that have been simulated within the digital scenarios. These are not great, but at least there is a capability of a proctor randomly causing a complication during a case you're working on. And coronary perforation is the big one. No reflow, coronary dissection. There are digital pericardiocentesis simulators, but probably pericardiocentesis is actually best learned on wet models, just from the feel. Evaulation, and your patient just comes out of cardiac arrest. And then obviously on the structural side, TAVR device embolization. What kind of studies are there out there in cath lab digital simulation? I think this is worth reviewing. There was a famous JAMA meta-analysis from 2011, where they actually pulled together every paper that they could find that had to do with simulation in the healthcare environment. And basically, they came up with this global statement. In comparison with no intervention, technology-enhanced simulation in training and health education is associated with large effects on outcomes of knowledge, skills, and behaviors, and moderate effects for patient-related outcomes. And don't forget that this is for every type of simulation in every healthcare environment. So can you generalize and apply this to interventional cardiology or cardiology training? Not yet. This is probably the most important paper in interventional cardiology simulation. And this was from David Holmes and John Messenger back in 2010. And this paper was published in an obscure journal, Simulation in Healthcare. But basically, it provided the framework for the 6 cases that exist within the ABIM module. And the goal of the study was to validate technical and cognitive evaluation tools using simulation for coronary intervention. They did include complications in some of the scenarios. They went out to 10 sites. They had 120 physicians from 3 levels of training, roughly a third novice, a third skill, and a third were defined as expert. After the study, participants were surveyed. 90% of them felt the cases were well simulated, and 60% felt the haptics were good. When you look at the ability to differentiate, what we see here is that the modules that were built were able to distinguish novices, but could not separate out skill interventionists versus expert interventionists. So it was best at separating novice versus everyone else. So the conclusion was that simulated cases can identify extremely poor performers, and they suggested the incorporation of these cases into either initial certification or recertification exams. I think 2010 was probably a bad year for the ABIM, and they therefore held back on pushing it forward into initial certification. And those cases have since been relegated, as we saw earlier, to recertification and getting points for medical knowledge. And as I suppose at this point, I would consider them to have stagnated there without any kind of data on their performance. Another, probably the next best paper specifically for transeptal puncture was from Hugh Calkins' group, and this was published in JACC in 2011. They used a Mentor simulator. There were 14 EP fellows with no experience that were randomized to either simulator or conventional training. and they would then perform 42 procedures without echo guidance, and that's how they were subsequently evaluated. In the conventional arm, there was a lecture by attending. There were then 5 mentored cases, and then they were then interviewed for assessment of their knowledge, and then things were repeated if the thresholds were not met. They had specific points. And then on the simulation side, you had the procedure attending, you had independent practice, and then you reviewed your simulator procedure reports for errors and discussion. And once again, you weren't allowed to go out until you achieve a specific threshold. In the evaluation of post-training performance, no feedback was provided during observed cases unless safety was compromised. And then the supervisors evaluated the difficulty of the case, and then recurrent errors were measured. And what did they find? Clearly, there was a decrease in training time compared to traditional training. And there was also a big difference in performance workflow and performance ability. So that was quite a strong effect of mentored training for transseptal access. We at the University of Arizona, try to focus on a very specific competency. I think that's probably the direction we want to move towards. And this was published this year at BMC Medical Education. We took 105 medical students, residents, and fellows, and we randomized them in a stratified manner. And the goal here was to teach a very simple thing, angiographic views. And I think for those of us who've been involved in education for years, we know how difficult that can be to for something that most of us at this point comes just it's almost subcortical. But in the initial phase, when we're trying to have people learn what view you're looking at a CAF film, that can take some time. So we thought, can we short circuit this? So we split our participants. We started a pre-test, and we asked them to categorize what view is this. We showed them 30 clinical angiographic senior runs so that we could get a baseline performance. We then had half the participants, everybody watch a standardized lecture on angiographic views by Morton Kurd, and then half of the participants spent 15 to 20 minutes manipulating a Mentis virtual C-arm. And we specifically use this a capability that you cannot see in real life, the overlay of virtual anatomy. And then we compared, and then we had everybody come back again and repeat the same test in random order and just look for what their performance was. And here is the setup. And you can see here that, you have this digital virtual heart. And what we find is that when your brain is learning from angiographic views, because you only see the arteries between shots, it's like walking around a tree, taking pictures of the tree at different angles, and then trying to reconstruct in your head what the tree is doing, versus the ability in the digital environment to see the tree constantly as you walk around it. Your brain forms that mental model much faster. And so we are utilizing that specific benefit of the digital environment. And what did we find? We found that in both groups, whether it was medical students, residents, everybody improved, whether it was the traditional method of learning. But overall, the most interesting group was the resident group improved the most. So we took people who were not necessarily even internal medicine residents, they were ER residents, family practice residents, etc. But we were able to get them to a fairly reasonable level with this 20-minute intervention. And you can see here that our interventional cardiology fellows, that effect is not as marked because they have already been exposed to the interpretation of coronary angiographic films. And so a short intervention like this is effective in early learners and can hopefully shortcut the process. And then we have probably the next most important paper from Toronto, from Akshay Bagai's group, and this was published in 2012. Basically, what they did was they took 27 fellows and it was stratified, randomized, similar to us, to a simulator, half, or no training. They basically had their cardiac cath performance assessed at week 1. And then all participants were then guided through 2 virtual procedures on the Mantis VISP platform by an attending. The attending then evaluated the performance via standardized forms. And then all participants received didactic lecture-based teaching, after which they were randomized. The control arm basically then went back to standard cath lab training, while the simulation arm for 1 week, in addition to standard training, performed mentor training until the definition here is a pre-designated level of proficiency to independently complete at least 1 procedure without being prompted or help was achieved. And they found that this training was achieved, this threshold was achieved usually over 1 to 2 sessions, over to 2 to 4 hours. And then the simulation group was then also allowed to independently practice on the simulator. And then this is an example of the technical performance score. So here they were a lot more ambitious. They tried to take the entire procedure, while we worked on a specific competency. And then this is the example, the type of global performance score, and it does take into account many things such as motion and whether you're making unnecessary movements, the maintenance of wire stability, choice of views, flow of operation, etc. And what they find, they also found the same thing. Technical performance scores were higher in the simulated group post-intervention, while they were marginally higher in the control group. And then the global performance score was higher in both groups. And it was a moderate effect. It wasn't amazing, but that's not bad for about 4 hours of time. The post-intervention scores, as a function overall of baseline obviously was a function of baseline pre-intervention scores, but in both cases, the subjects undergoing simulation had higher gains compared to controls, as you would expect. There was a very interesting study that came out of Sweden, which has led the field of simulation training. And they've been doing this coronary angiography course for many years, since 2006, and it's a national course. And during the course, they have 2 simulators, 3 instructors, 6 participants. They do 6 hours of Proctor Mantis simulator training over 2 days. And what they did here was, because of the National SCAR Swedish registry, they could then track the outcomes of the patients in whom the trainees, so because it was linked directly to the trainees, they could see how those patients did after those trainees came for this course. It's interesting, they had 54 residents, but only 12 became invasive cardiologists. The goal of the training was safety, minimizing contrast, and good use of angiographic projections. And then they used a retrospective cohort of novel operators as the control group. And then the 12 of the simulation participants were identified, and they were compared against 46 controls. And what did they find? They find that median fluoroscopic time was actually higher in the simulation participants versus control. There was no difference in contrast volume, and the complication rate in the people who underwent the simulation training was actually far higher than in the control groups in real life post-cath lab complications. They didn't quite know what to make of this data, but given, I think, the clear non-randomized nature of the study, it's quite an interesting study in its construct. I'm not sure whether you can actually make any conclusions. It's possible the reason why complications were higher were simply because these were the trainees that then chose to do interventional and probably more complex cases. There have been either other minor studies from Northwestern with 14 fellows, and this is once again didactic teaching versus 2-hour preceptor training, and you can see once again that there is some moderate amount of effect, specifically with regards to the skills checklist, and this is most pronounced in junior fellows, in first-year fellows versus third-year fellows, as you would expect. There's been, this is a study from the German Collaborative. This is probably Wolfram Volker runs a national German training center. In Germany, points are awarded for the completion of training for attendance at these training courses, and there are 2 national sites in Germany. And so their models of utilization or simulation are a lot more organized than ours. And pretty much all trainees in the German system get exposed to these courses at some point. And then University of Illinois, same type of stuff. Very, very small studies. It's almost amazing that you can publish off 3 fellows and their outcomes. But I think the details are less important. But it's I think important for the group to see how poor the data is overall. So I think to conclude, what do we know so far on all the papers and simulation? You can see that most of them are spread out over almost a decade. All the studies are small and limited. There is good to fair evidence for improvement in performance. Many programs use full hybrid models of simulation, where you're trying to be ambitious and take the whole procedure in with fewer focus on specific tasks. These models tend to be very resource intensive. You require proctors, they're complex curricular, and the simulators are expensive. And patient outcome, as you can imagine, is not well studied because it is very difficult to track. In Arizona, we've been conducting a quarterly regional fellow simulation course for at least the last 11 years, for over a decade now. We do it and we open it up to all 4 Arizona fellowships. So it's a statewide thing, and it's bounced between University of Arizona and Tucson, as well as Mayo Clinic, Arizona. We average 20 fellows per session, and we recently completed our 24th course. So January, we'll see our 25th course. These are all the different task trainers we have used during the fairs, and you can see which are the ones that are most popular. We get our fellows to rate how they feel about it, and this is a word bubble as to trying to bring together the subjective feelings and opinions as to how people felt after they finished these things. The lessons we've learned is that small group learning is most effective, but you then therefore require a large number of simulation stations. Mentor training is most effective, but is extremely demanding on faculty time commitment. Usually when I do these things, I stand at various stations almost for 8 hours a day. For it to be effective, you must define your objectives, and industry participation is unavoidable if you want to have a full spectrum of exposure due to the cost and access to simulators. Simulation is most effective for junior fellows with basic procedures. For senior fellows, advanced procedures, they find that most helpful, as you would expect. So I'm just going to try and wrap up here. What are future directions? And before we look at the future, it's worthwhile looking at the past. This is the current state of medical simulation from Sky in 2014, from a paper by Sandy Green, Andrew Klein, John Messenger, Jeff Marshall, and Sunil Rao. And what did they find at the time when they took the temperature? They basically saw that uptake was low. There was a lot of skepticism on efficacy and fidelity. There was a lack of expertise or familiarity in how to use these simulators. There's a lack of proven curriculum. The ratio of faculty to trainees was prohibitive, and then the access and cost obviously is prohibitive. There was a survey that was sent out to 132 US cardiology fellowship programs. 24% of programs were using simulators despite the ACGME statement. The majority of programs use computer-enhanced mannequins, such as the ones I've shown you. They use up to 2 to 10 days per year, so very low exposure. Most noted that simulators were good for low-volume procedures. They felt that they helped trainees with initial understanding, but did not replace real patient experience. Few programs felt that the fidelity was high, or that improved skills and the financial burden was significant. So they had recommendations for the future. They say basically that Sky, in conjunction with ACC and ABIM, developed a set of standardized cases that embody the essential psychomotor and knowledge required for interventional cardiology, such as the ABIM cases that I described. They say that this should be integrated into a standardized didactic curriculum that meets ACGME and COCAT's learning standards, and that these cases should be on all simulation platforms, not specific. And then they advocated for large-scale studies evaluating the impact of simulation. And that formal simulation finally be integrated into annual meetings. Of the 5 statements, only the last has occurred in the last 8 years. Formal simulation training programs tend to now be, they're quite popular and they are integrated into annual meetings, but we have made very little progress in the first 4 dictates for the future. So these are my thoughts. I'm just going to wrap up here with what I think should be near future directions. I think that we obviously need to work to construct and integrate simulation-based curriculum into standard cardiology education. This probably is best done in the form of a cardiovascular simulation research collaborative network. And then we need to, I think, be very granular and aim for competencies and maybe not aim for entire cases. And we need to also obviously generate evidence for this efficacy. The things that we should focus on, similar to our 2022 training statement, should be complications and difficult and complex, as well as uncommon procedures. ER programs around the country have created simulation fellowships, and maybe that's something we should think about for the few people that might be interested in this field as they move into careers in education. I think that the platform should consider building cloud-based personal portfolios with Rosetta Stone interactivity between platforms that can track simulation and hopefully in the future integrate that with real-world performance. This is not a great idea, but I think, unfortunately, you cannot avoid the idea of gamification because people enjoy competing with one another. And it's a big stimulus. Dopamine is a big stimulus for behavior. And we need to think about that. And then we should continue to validate simulation as a testing modality for both initial certification and maintenance of certification. One thorny topic that's been talked about over the years is how it also plays into credentialing for the continued maintenance of credentialing within hospitals. That's a completely different topic, but I think apropos to how simulation can be used in the future, but it tends to generate a lot of a noise every time you bring it up. And then obviously, I think, we don't need to reinvent the wheel at every site. All the programs that have successfully launched simulation programs should develop a toolkit that can be implemented for programs that are interested. We should help each other for financing and running simulation programs. And this is a Black Mirror view of the future. And this is my partner in crime, Dave Fortune from Mayo, Arizona, who's been very involved in simulation over the years. But this is the kind of thing when we talk about gamification. As he works in a simulation environment, perhaps we need to do this. We need to generate a global ranking of performance during our cases. We've floated the idea, but been shot down every year at ACC and Sky, of having interventional simulation competitions, say for door-to-balloon time in MI, etc. But I don't think we're quite ready for that in an open space. But maybe this is the way we should go. All right. Thank you. Thank you for listening. And I am happy to take questions at this juncture.
Kwan, thank you very much for a very interesting talk on an important topic. I'd like to open it to the group for any questions or comments.
Hi, this is Samit Shah. Thanks, Dr. Lee. That was a really fascinating talk. I just had a quick question about how you incorporate simulation with hands-on training. So if you make the analogy to pilot training, simulation is complementary to flight hours. And so how do we make sure that trainees get enough hands-on hours as well as simulation?
Yeah, thank you, Samit. That's an excellent question. What we found at our site actually is that you have to have the simulator as close as humanly possible to the place where you normally work. If it's possible to have it in a cath lab, you need to have it in a cath lab. We have it next to our fellows office, and we built a little room with a full suite of simulators. And so when our fellows start to rotate through the cath rotation, we give them very specific tasks. We have them practice different catheter shapes and engagement. We have them practice the radial approach and the interesting behavior of the Tiger catheter. As we all know, it's quite different compared to how JL Judkins catheters behave. And then we also have them work on, there is a module with bypass graft anatomy We have them work on that until we are, or they feel like they're satisfied. But what we found though is that even though proctored training is best under these circumstances, we are only able to proctor them in the initial part, and we then have them, we show them how to turn the machine on and hopefully not break it. But yeah, it has to be embedded. What we will find is that the further away you move it from where people normally work, you have exponential fall off in daily use and engagement with the simulator.
Hi, Dr. Lee. This is Steve Pfau. Thank you very much. That was an interesting talk. Obviously, uptake and funding for these kind of efforts is going to depend on demonstration of some effect.
Yes.
Both in terms of how the fellows do and also how the patients do. Is there any lessons from flight simulation or military simulations about how to prove the effectiveness of the simulation training?
Yeah, that's a great question. With flight simulation, you almost need a perfect storm, right? Because these things are very difficult to develop, and so we're caught in a position where if you don't have economies of scale, the price point is prohibitive. And like I said, a full suite Mentis G7 Plus simulator clocks in between, usually low ball, if you don't take all the modules, about $120,000 to about $200,000. And so unfortunately as well, because these modules are not open source developed, you need to work directly with the companies to improve the modules. And there are times when I feel like I'm pushing a stone uphill, even though I built or I helped design every single one of the modules for the beginner, intermediate, and advanced suite that they have right now. There's still a lot of work that needs to be done. And if you don't have that feedback loop, and I think in military and flight simulation, they obviously have very large budgets. The consequences of failure are extreme, and therefore the desire to and the fundamental baking in of simulation into their daily practice, was seared in early on. And for us, we get distracted by so many things. We get distracted by patient care. We get distracted by, all the things that we have to do. And so, we are stuck. We're stuck in this point where you can't proceed, and yet you have to proceed, right? The philosophical position should be it's not good enough, let's just ignore it for a while. The philosophical position should be, it's not good enough, we need to make it better. And that, I think, takes you just need to plant a flag and say, this is my position and I will do this. And so just as from a toolkit perspective, the funding has to come from the philanthropic arm of our institutions. There's no other way you can do this. That's what I had to do on my side.
Thank you.
Kwan, you talked about haptic feedback in some of these machines. Of course, we have cases where the guide backs out, or there's a certain feeling as we go through a bifurcation or calcium. What's the haptic feedback like on simulators these days?
So it depends. Yeah, so it depends on what you're referring to. If you're referring to the guide haptic feedback, it's not bad. It's probably a 60% fidelity. If you're talking about wire haptic feedback, it's lower for sure, because it's very, very difficult to have that kind of complexity of a digital fidelity. Probably about 30%, I would say, your coronary wires as they advance through difficult anatomy. Your balloons and stents, not great. And so I think therein also lies the problem, right? It's very difficult to build haptic models that are good enough. But I think the Corindus robot has actually, we keep talking about how important haptics are, but if you look at people who use the Corindus often, I think, especially if you have fellows operating in front of you, most of us have actually learned we can convert what we're seeing with how the wire is behaving into haptics in our head. And most corindus operators, that's what they'll tell you as well. They are initially saying, oh, the haptics are super important, but ultimately they've learned how to translate the visual behavior of tools into what it should feel like. Clearly, that's not a place we should be starting with, but I think that's maybe in the future, with the corindus, it might actually give you numbers as to the pushback. What kind of resistance something is encountering.
This is Samit Shah again. So another question I had was about the last few slides you showed about competency assessment.
Yeah.
How do you add proctoring into that and, kind of lifelong learning and improving performance with a proctor versus simulation?
Sorry, I don't quite understand your question. You're saying what's the difference between a proctor and a simulator, or?
Well, yeah, I mean, I guess at the society level, is there additional conversation about proctoring and improving competency that way rather than simulation, or combining both?
I think the best environment is obviously using both. Simulation is just a tool. Clearly, as the modules get better, you can really hopefully at some point be able to build simulation task training that achieves very specific competencies. I think the big struggle as well is that the companies that build the simulators tend to think that their models simulate real life when they really don't. And so you have to get very granular as to what exactly are you learning when you're doing this, and which parts of it are actually the most effective for training something. What I find for the radial engagement with the Tiger catheter, there's a very specific behavior about the Tiger catheter where as you clock from the left side to the right side, the Tiger catheter, because of its 90-degree angle, rises higher. And that's not something that happens on the other side. And this, in the simulation environment, is very easy to train fellows how to respond to that. I think we just need to be more granular and more precise about what it is that the simulator is good at, and harness those strengths, and then understand that there are some parts of it that you're just never going to get to fidelity. But specifically for difficult, complex tasks, like how do you, can you remember every step of the DK crush? Can you remember every step? Turn off the phone here. The phone is going off.
I can hear you now, Kwan. You're back.
Yeah, sorry. Yeah. Okay.
Hopefully
that was helpful.
Thank you very much. So we're coming up on 8:30. Any other questions or comments from the group for Dr. Lee? Well, thank you, Kwan, for a wonderful conference, and have a wonderful rest of your visit in Colombia, and look forward to seeing you at one of the meetings.
Yeah, thank you, Rob. Just a quick question. Do you have a simulator? Just out of curiosity.
We have not at the level, obviously, that you guys have. During orientation, actually, Dr. Shah works with, and some of our other faculty work with the fellows. And I think if Samit, you're still on the call, wasn't there a Philips simulator that we worked with it from time to time?
So Terumo brings a few simulators every year. We do a cath lab boot camp, and so we have a radial access simulator. We have an aorta model, which I think is actually super helpful to see the way the catheters move inside of the ascending aorta. And then the last thing, they bring a Mentis angiographic simulator as well.
I see. But it's just once a year in the beginning part, right?
Yeah. So I mean, there's a lot of interest in doing it twice a year, but obviously, as you know, it takes a lot of effort, and so hopefully we'll do it more often.
All right. Okay. Thank you. Yeah. If anyone's ever interested, as we put together our, we really need to develop research collaborative networks, and we have to design. It's hard when you only have it for once a year, but hopefully this will stimulate some interest.
Thank you very much, Kwan, and have a great day.
All right, thank you, Rob.